Hello, my name is Dr. Melissa Latorre, and I am a clinical fellow in gastroenterology and hepatology at New York Presbyterian Columbia University Medical Center. Today I have the pleasure of discussing a manuscript that has been accepted for publication in gastrointestinal endoscopy, entitled Endoscopic Biopsy Technique in the Diagnosis of Celiac Disease, One Bite or Two, written by myself, along with Dr. Stephen Lagana, Daniel Friedberg, Suzanne Lewis, Govind Bhagat, Benjamin Lebwall, and Peter Green. The gold standard for diagnosis of celiac disease is a biopsy specimen obtained from the proximal small intestine that displays villus atrophy, crypt hyperplasia, and intraepithelial lymphocytosis in a patient with clinical features of gluten sensitivity. Guidelines recommend that 4 to 6 separate biopsies be obtained from the proximal duodenum when celiac disease is suspected. This is due in part to the patchy nature of disease, but also to the low yield of adequately oriented biopsy specimens. A well-oriented biopsy specimen is defined as a piece of intestinal mucosa that displays 4 consecutive parallel cryptovillus units. Previous studies have found poor rates of adequately oriented specimens, which greatly limits the diagnosis and management of celiac disease. To minimize procedural time associated with the acquisition of 4 to 6 specimens, endoscopists often take double biopsies, or 2 bites per pass of the forceps. Another method to obtain these specimens is to obtain single biopsies, or 1 bite per pass of the forceps. In clinical practice, the choice is made according to the clinician's personal preference. However, the effect of these 2 techniques on the quality of small intestine biopsy specimens is unknown. There are a few studies evaluating the effect of biopsy technique on the outcome of histopathology. None have compared the single and double biopsy techniques in upper endoscopy or celiac disease. The primary aim of our study was to compare the number of well-oriented duodenal biopsy specimens obtained with the single and double biopsy techniques. The secondary aim was to compare differences in Marsh score with these 2 techniques among patients with suspected and confirmed celiac disease. Our study was performed at Columbia University Medical Center from August 2012 to February 2013. We enrolled patients 18 years and older with known celiac disease, suspected celiac disease based on serology, family history, and symptoms, and patients with unknown celiac disease status. 3 gastroenterologists performed the endoscopies. Each patient underwent a standard EGD with a total of 4 biopsy specimens taken from the second portion of the duodenum. 2 specimens were obtained using the double biopsy technique and placed into a specimen container. Then, an additional 2 specimens were obtained using the single biopsy technique and placed into a separate container. An experienced GI pathologist, blinded to indication and biopsy technique, reviewed all specimens to determine the adequacy of orientation, the total number of biopsy specimens, the total number of cryptovillus units, and finally to assign a modified Marsh score. Biopsies were considered well-oriented if they manifested 4 consecutive cryptovillus units. Specimens with fewer than 4 consecutive cryptovillus units were considered to be of poor quality. A subset of randomly selected specimens was evaluated by a second GI pathologist to determine orientation only. Differences in outcomes between the single and double biopsy techniques were analyzed among patients with known, suspected, and unknown celiac disease status. 2 additional subgroups were established by incorporating outcomes of histopathology. The subgroup of patients with the final diagnosis of celiac disease included patients with known disease and those with suspected disease who were found to have villus atrophy on biopsy. The subgroup of patients with villus atrophy included all patients found to have villus atrophy on biopsy. A total of 86 patients were enrolled in the study, 69% female, 31% male. 47% had known celiac disease, 36% had suspected celiac disease, 17% had unknown celiac disease status. Overall, 66% had well-oriented biopsy specimens with the single biopsy technique, and 42% had well-oriented specimens with the double biopsy technique. Improved orientation with the single biopsy technique was also observed upon analyzing matched pairs with an odds ratio of 3.1. Our findings with regard to our primary aim achieved statistical significance. Significance persisted on analysis by a second GI pathologist and in subgroups of patients with known celiac disease, villus atrophy, and a final diagnosis of celiac disease. We also found greater incidence in the loss of one specimen with the double biopsy technique, as well as fewer consecutive cryptovillus units. Both these results achieved significance. With regard to our secondary aim, there was a trend towards increased severity of Marsh score in specimens obtained with the single biopsy technique. However, this result did not achieve significance. In summary, our results demonstrate improved orientation of biopsy specimens with the single biopsy technique compared to the double biopsy technique. Future studies should formally evaluate the use of the single biopsy technique in other disease processes that are dependent on histopathology. Given the low yield of well-oriented specimens in the evaluation of celiac disease, we recommend that endoscopists consider taking only one biopsy specimen per pass of the forceps in patients undergoing biopsies of duodenal mucosa. On behalf of my colleagues, I would like to thank Gastrointestinal Endoscopy for the opportunity to present our manuscript. We hope you'll enjoy it.